Finding Hope, the Road to Recovery.
Hello, my name is Keith Starr, and I am a licensed marriage and family therapist, and I am the director of the Inpatient Hospital at Tarzana Treatment Center. In today's episode of Road to Recovery, we're going to be talking to Dr. Antionette Olivarez, who is the Director of Nursing, also on the inpatient unit at Tarzana Treatment Center. Good afternoon, Dr. Olivarez.
Good afternoon, Keith.
So Dr. Olivarez and I run the inpatient psychiatric hospital at Tarzana Treatment Center. We're an integrated healthcare program, and today we're going to talk about what it's like in a day on detox, where we do withdrawal management for those people that want to get off alcohol and other drugs. So Tony, can you give me a little idea of what it's like to walk onto the unit once a patient has been admitted to the program and fully assessed everything, they're ready to participate in treatment?
Yes. So our nurses on the unit will greet the patient and will begin the assessment of the patient. They will ask questions. They will do vital sign assessments. They will consult with other providers that are on the unit. For example, perhaps maybe our counselors, our technicians, and our providers that are also on the unit. After they complete their assessment, then the patients will be escorted to their rooms where they'll be able to rest and prepare for the next phase, which includes things like receiving medication for their withdrawal symptoms if they're having it, getting prepared for meals and groups, and being oriented by the counselors and technicians to the day at Tarzana.
So I'm familiar with the counseling portion because that's my part of the unit where you're more on the medical side of that. So yes, so I know that when a patient arrives and they are assessed and met by our staff, they are involved with the counselors to kind of get oriented to the unit to make sure they know where everything is, their room, where the groups are, who the staff are, and any other particular needs that they might have, where to go, where the phones are, et cetera, et cetera. So if you can just talk to me a little bit about, I know that we do detox withdrawal management for multiple drugs. If you can walk me through what it's like for, let's say, somebody coming in for alcohol, who is abusing alcohol and is in need of treatment with protocols and how that operates.
Our nurses monitor these patients very closely, especially the patients from alcohol who are withdrawing from alcohol. They come in all different phases and stages of alcohol withdrawal. Some of them may actually not even be in withdrawal yet, while others are already in withdrawal. It really depends on the assessment and how the patient is presenting. And then based on that presentation, our nurses will be in contact with our providers who will prescribe medication to assist them with their withdrawal symptoms so that they are more comfortable and they're able to rest and get through that initial phase where they could feel uncomfortable, but we try to medicate them to help them get through those difficult symptoms.
Okay. Are there any specific medications that are used for alcohol withdrawal?
There are various medications. At Tarzana, we will see a lot of Transine being used. And then there are some other medications that they can go on as well that can help them with other symptoms for their stomach, for pain, for cramping, and things like that. And this really depends on the individual patient and what their symptoms are.
Okay, thank you for that. So in conjunction with that, for my part with my team on there, I know that we work very closely together, the counselors and the therapeutic team with the nursing team. We evaluate what the patient's needs are. While you're doing it on the medical side, we're doing it on the psychosocial side to see if they're homeless, if they have a home, what stability or instability they have in their life. We do team meetings with all sorts of staff that we have. That happens every 3 days on our unit. Can you talk to me a little bit more about what the nursing department looks for during those team sessions, and then I can elaborate on what the other parts are?
I would like to stress here that it's a very interesting dynamic on the unit. Sometimes a patient may identify with one particular staff person. It might be a nurse, it might be a technician, it might be a counselor, it might be a provider. sometimes those patients will share with that person more than they might share with anybody else. This is the teamwork that Tarzana really works hard to maintain and include the patient in that treatment care. So when that patient does speak to a nurse or a counselor or a technician about something special or an individual need or concern or symptom, what we'll do as a team is we'll come together and we will try to discuss those symptoms and concerns and then figure out which team member can best address it with the patient. Sometimes the patients are receptive to other people, and then sometimes they stay focused on one person. Again, it really depends on the individual, but for the nurses, we focus heavily on their physical aspect. But the thing is that we have to be aware and we have to be ever watchful for the psychosocial symptoms that they may present as well. And then when we do see those kind of things, we want to bring them to the counselors, to the providers, to the technicians, and try to develop the treatment plan with the patient that meets all those needs.
Okay, thank you for that. I meant to mention earlier that we do have a medical director who oversees the unit for all the counseling, all the medical services that we do provide. We also have a team of psychiatrists that are on the unit, as well as postdoctoral students, psychologists, licensed marriage and family therapists, licensed clinical social workers, certified counselors, and peer support technicians. Just wanted to make sure that when we talk about the team, it's quite large. So we really need to make, to talk about everybody and their involvement with that. What do you see today as one of the primary drugs that people are abusing? I know we talked a little bit about alcohol. People also are prescribed other medications that they may abuse, like Xanax, the benzodiazepine type of family, as well as physical pain, opiates, et cetera. Can you talk a little bit more about the variety of drugs that we see coming in onto the unit that we treat, please?
Just about any street drug that's out there today, we might see on the unit with the patients. But what we're seeing a dramatic increase in is the abuse of fentanyl.
Yes.
And this is a very serious and very concerning situation, not only for the patients, but for the staff as well. We also are seeing a big increase in methamphetamines. Well, research will tell you that oftentimes opiates and methamphetamines go together because of the a feeling of going down and up and up and down, kind of a feeling that a patient may want to experience or feel the need to experience. Oftentimes we'll see the patients come in and they're abusing something like Xanax, like you mentioned, benzodiazepines. Many of our patients will come in and they didn't intend, obviously, to use them as a recreation. Many of our patients were prescribed them, but over the course of time became dependent on the medication and used it more and more. It doesn't matter why they started. It doesn't matter how they started. The fact is that they need to try to get off of those medications for their own health and safety and social well-being. So that is our goal. We are not there to judge them. We are not there to criticize them. All we're there to do is to help them through their withdrawal. And so, as you had asked, fentanyl, methamphetamines, benzodiazepines, and interestingly enough, even though it is legal in California, we do see a fair share of cannabis.
Mm-hmm. Yes, thank you for clarifying that. I too have noticed that there has been a increase in fentanyl use. Interesting thing is you had mentioned methamphetamine, and while sometimes there are those that come in for polysubstance use disorder, meaning utilizing multiple drugs, it's we've seen that methamphetamine only patients that come in the door, and when we do a drug screen on them, because we test for every drug possible so we know exactly what to treat, because some of our patients aren't always honest, and while they may be drinking, they may not tell us that they're taking Xanax or another drug, but we have found that methamphetamine only type users are testing positive for fentanyl. And it's very important for our viewers to know that any drug can be cut with fentanyl. Yes. So we're seeing a huge amount of patients that have never used or abused opiates, yet they're testing positive for this drug, which is very, very dangerous. And we do treat them for that as well. They may not quite understand why they tested positive for that, but it's important for us to treat the whole person in that regard. So yeah, it's pretty serious. I too have seen the marijuana today is much higher in THC levels, which is the cannabinoid that gets you high, basically. It's not like the marijuana that was around 20, 30 years ago. It's very high-bred. It's a very unique process now of growing. So we have seen patients coming in that go into almost a psychosis just for using marijuana. So we notice that patients who may not use one drug or another and come in specifically for something, that they are going to be treated for other specific drugs. And there are medical concerns too that we have with our patients. And maybe you can talk a little bit more about what medical issues you see with patients coming in today that these drugs and alcohol affect on the body.
It's very interesting to assess these patients that are coming in. We might see patients that are coming in off the streets and they've lived there for a long time and they have their own unique set of medical issues. Some of them come in, and they need overall general hygiene care, which is actually affecting their overall health as well. Poor dental care, poor habits of eating, and so on. This really does impact how they're going to go through their recovery. We also see patients that come in and they don't know exactly what's wrong with them. They may have an enlarged liver because of drinking so much alcohol. They may have infections and abscesses because of shooting, intravenous drugs or intramuscular drugs. There's also something called skin popping where they hope they do it in like more of the subcutaneous areas. The thing about this is that oftentimes the patients come in and they're way sicker than they think they are. And then we have to also address, of course, those medical issues. And we do this by running the appropriate testing for them. And if needed, they may even have to go to a higher level of care, which means sending them into another acute facility where they can get things like intravenous antibiotics and other tests like MRIs and CAT scans that we don't perform at Tarzana.
Okay. So it's fair to say then on the unit, we're not just detoxing a patient off of a particular drug, but we're treating the whole person.
Absolutely. We have to treat the whole person. The whole person is who they are. I'm even speaking about their psychosocial issues. If we help a person go through a withdrawal and we successfully detox them from drugs and or alcohol, and they have no place to go, and they're going to go back into a negative environment where they're going to be confronted with alcohol and drugs again, the relapse risk is extremely high. As we all know, substance use disorder, as it is called as a generic umbrella term, is actually considered to be a chronic relapsing brain disease. And as such, we want to try to get in front of that relapse and try to educate them and help them get through those rough spots. Hence, it's called early recovery. And that is where, as you might have seen in some earlier episodes with Tarzana, where we encourage them to go to a lower level of care where they still get guidance and treatment and therapy and so on. So Tarzana is really a very progressive program, and it allows the patient to go through a continuum of care all the way through to getting back home and becoming a successful and happy person in their life and environment as well.
Yeah, I believe in some previous episodes of this show that our director of the residential program spoke about that. So the inpatient unit, as we call it, where we do psychiatric stabilization and withdrawal management, is just a start.
Absolutely.
To medically stabilize them, to get them address their mental health issues, which we'll discuss a little bit more in our next segment, and then to find a level of care that's appropriate for them. Part of our team includes case managers or care managers. The care managers work with the patient from the moment they arrive. Well, it may be the next day if they're not feeling too well. We want to make sure that they're comfortable, to work on those discharge planning areas of where they need to go. Because as you mentioned, if they're going to be going back home and there's a significant other there that is also using, the likelihood of them staying in recovery and sober is very, very small. If we're able to step them down to one of our residential programs and then have them there where they can actually, in a sober manner, begin to work their program and really go to a lot of groups and get individual therapy and counseling, that they, the longer they're in treatment, the better chance they have of that.
Absolutely,
Yeah.
absolutely.
And you and I both know that that is a challenge to find an appropriate next level program for them. Some of our patients are very willing to do that, and some unfortunately are not very willing, and they're a little bit resistant to that level of care. And I think that's something that you and I see, unfortunately.
I think it's important right here to mention that sometimes patients will come into Tarzana to detox and withdrawal from drugs and or alcohol, and they find that they're just not quite ready to do that. There are many reasons that they're that they give. It could be that their families are not quite ready for them to be away from them for any period of time. Maybe they have a job they have to go back to, or maybe they just are scared and they just don't feel like they can do this without the crutches that they've been using for so long. The nice thing about Tarzana, the great thing about Tarzana, is that we don't judge that. If they're not ready, they're simply not ready. We want to offer them counseling, outpatient services, psychiatric services, psychological services, social services. And when they're ready to come back in, we welcome them. We want them to come back. And we want them to face it and to deal with their own recovery when they're ready. Because when they're ready, they have a better chance of success.
Right. And that's a perfect time to segue into what we call medicated assisted treatment, which is MAT. And that is other treatment options instead of coming on an inpatient unit. While we do medical assisted treatment for the benzos, the opiates, and transient for alcohol, as you mentioned, we can also do that on an outpatient basis.
Absolutely.
And for those patients that come in multiple times, maybe there's a better solution for them to come to one of our outpatient programs and see our physician providers to get their medications for them, and they can function, sometimes a little bit better. In that we've seen that.
I think that we should consider too that after they withdraw, this isn't the end for them as far as being medicated and receiving care and services, as you just mentioned. So sometimes our patients, especially our opiate patients, they need more assistance with staying sober, staying in the recovery phase. And as you mentioned, this is where MAT, or medicated assisted services, come in. Medication assisted treatment comes in. We offer this both in the residential area and in an outpatient setting. And what we're trying to do is we're trying to help these patients with a very particular long-term opiate use and difficult withdrawal and addiction process. We give them something called methadone or Suboxone, which is approved medications to help them maintain sobriety, maintain that sober type of lifestyle, and be able to function in society, get back to work, get back to their families, and help them with a longer process, yes, but help them get off of opiates for their lifetime. Sometimes people need that help. Opiates is a very serious and potentially deadly addiction. And the sooner that person gets into program, and if they need that additional help of the medication-assisted treatment, Tarzana is there for them to help them with that.
We also use another medication-assisted treatment called Vivitrol. Can you describe a little bit about what Vivitrol is? Because I know we use that for alcohol as well as for opiates. We're actually one of the largest, if not largest, provider of Vivitrol in LA County.
Vivitrol is a really good drug, and it's there for both alcohol, as you said, and opiates. Vivitrol is the kind of drug that you don't get high from this, okay, but it does help you curb that desire to drink, craving, exactly, that desire to drink or to use drugs. This is an extremely important aspect of early recovery and then long-term recovery and sobriety for the patients. Vivitrol is often the drug of choice for many.
Well, thank you for that. So I just wanted to just kind of wrap this up here that Tarzana Treatment Centers Inpatient Unit, we deal with detox or withdrawal management to have a safe place for the patient to go through the initial phases of treatment. And with our team of doctors and staff and nurses, we want to provide the next level of care for them so they go through the full continuum of care within Tarzana's system, or if it's within the community or back at home, that we want to give them the tools that they need so they can utilize them in their journey into recovery. Thank you, Dr. Olivarez, for your time. I appreciate that.
You're
Thank
welcome.
you very much.
Can you tell which of these children was not born free? Can you tell which of these children was not born equal? Can you tell which of these children does not deserve to be treated with dignity? We can't either. Human right number one. We are all born free and equal.
Hi, welcome back to Finding Hope, A Road to Recovery. This is Keith Starr. I'm the director of the Inpatient Unit, and today joining me is Dr. Antionette Olivarez, who is our director of nursing. In our previous segment, we talked about our withdrawal management, or a day in the life of detox, and what it's like to go through a program where you are physically coming off in a safe environment of the drugs and alcohol that may be using. In this segment now, we're going to move into more of some of the mental health issues that we also treat. We are a licensed psychiatric unit. Tony, if you want to, I know her as Tony, Dr. Olivarez. If you want to maybe explain a little bit more about how our unit operates.
Tony's fine, Keith.
Thank you. Okay.
Well, as we had talked about in the last segment, we admit many patients that come in who are using drugs and alcohol. But the interesting thing about these patients is that many of them have something that's called co-occurring or dually diagnosed. When we talk about these types of things, we're talking about a psychiatric or psychological problem that they're also dealing with. Sometimes these are actually drug-induced, but sometimes these patients just have such overwhelming problems going on in their lives that they do have these other problems, anxiety and depression and things like that, that they need help with, especially as they're trying to go through recovery from drugs and alcohol. The anxiety kind of increases. The depression about being away from their family and friends can increase as well. So we are a way station, so to speak, because we are still a voluntary program, which means that our patients, if they're not ready, they can leave us. But we do have psychiatrists, psychologists, people that have just gotten out of school that we call postdocs in our area, but they're psychologists by degree, and they're working with our patients because that is their choice and their preference to be with us. And then, of course, all of our staff are also trained to help the patients who are dealing with some psychiatric or psychological problems that they bring with them.
So part of our process, as we discussed a little bit before, is our assessment process. People call us for services, people walk into our facility for services, and we also get referrals from other hospitals, other programs, community resources, family and friends, etc. So when a patient walks into our doors, we look at all of that, right?
Absolutely.
We look at if there's an substance use history, mental health history. You spoke a little bit about the medical history that we have before. We do a triage up front, utilizing ASAM criteria for withdrawal management and level of care. And we also do our independent psychological evaluations on patients where we get the family history, the biopsychosocial, which we mentioned earlier, as well as what medications, what other hospitalizations. So it's fair to say that there's a very thorough assessment process that is done. And when we do find out that there's a mental health related issue that may have been undiagnosed or being masked by alcohol, I guess what you can say is that we bring in that team to further assess and treat for both. And there might be some different medications now instead of just withdrawal medications, but there might be some psychotropic medications. Can you talk a little bit more about that, about how our psychiatry team meets with the patients for patients that come in with dual diagnosis or comorbid issues?
Absolutely. You mentioned ASAM and biopsychosocial. I was wondering if you could just, before I go into that, break that down just a little bit more for the people that are listening.
ASAM is the American Society of Addiction Medicine. They are the entity that has developed proper screening tools over the course of many, many years to determine what the patient presents to multiple questions and assessments of the appropriate level of care, where somebody might meet level of care for outpatient, where they may not need to come into an inpatient. The detox is the highest level. Then we'll go to residential, multiple levels there, and then outpatient, partial hospitalization, and MAT services, as we talked about as well. So it really helps us to determine what their dimensions, as they call them, for medical, psychiatric, substance use, social environment, relapse risk, etc. Helps us place the patient in the right level of care. And whenever a patient completes a certain level of care, another ASAM is done to determine what level of residential, because there are 3 levels of residential or multiple levels of outpatient. So that's pretty much what ASAM stands for. Thank you for letting me clarify that.
And just one more thing to make clear is these assessments are painless assessments. These are not physical assessments.
No, they're not.
These are psychiatric, psychological assessments where in the privacy of our own, in the patient's rooms or in our doctor's offices, where the counselors and the psychologists and psychiatrists can meet with them privately and discuss things with the patient, correct?
Correct.
So when these patients come to us, the nursing team is also very well trained in taking care of psychiatric patients. And sometimes we don't even know that the patient is coming in with a psychiatric issue, or we may know in advance that they have one. The nurses are trained to observe and to monitor the patients not only for withdrawal symptoms and physical symptoms, but also psychiatric and psychological symptoms. And whether or not they know that the patient has a problem or not, they're still trained to always be ever watchful for that. Because sometimes the patient, like I said before, doesn't even realize that they have some issues going on. And as they get sober, as they go through recovery, they become exaggerated for them. They see them, and they need some help and guidance in those areas. And that's what we're here for. We're not going to take care of them so and lock them down and make them so heavily drugged and regulated that they can't get up and actually leave if they want to. That's an important thing, I think, to stress. Our patients are not restricted, they are not restrained, they are not confined in any way. We want our patients to feel better, deal with what they're addressing right now, what they're facing, what they're feeling. But again, we're a voluntary program. So when we talk about psychological and psychiatric, I want to just assure everybody that in our setting, we're not dealing with somebody who might need to be in a higher level of care and is dealing with a severe case of psychiatric or psychological issues. If we decide that somebody is becoming really sick, then we would, of course, send them to another level of care that can handle them as they grow sicker and then deal with that. So in our area, our psychiatrists and our psychologists and our postdocs and the rest of our team are assessing and monitoring for the psychiatric, psychological concerns, and then we have medication to help them. We are very careful with those medications because we want to make sure that it is a safe withdrawal, safe with their detox medications. And then what we do is we begin slowly with those medications and bring them up on perhaps maybe an antidepressant or an anti-anxiety medication. And sometimes they don't need it for long term, but to get them through the early phase of their recovery, early phase of detox, so that they can deal with some of the problems that they're going to be facing later on. It's really a way station. That's how I look at it. It's a place where somebody is struggling with some psychological or psychiatric concerns, can come, can feel safe, and can get some help, get some guidance, get some counseling, and hopefully get some medication that will help them feel more comfortable as they go through the whole process.
Thank you for that. That's very, very helpful information. I also wanted to mention that, as we talked about in the beginning of our triage and our assessment, it's at that particular point where our psychological staff will place them on our psychiatry staff, who's on during the day or during the evening. We have different shifts with our doctors for that, to evaluate what meds they brought in for their mental health disorder, or if they didn't bring any medications in, what medications we might be able to prescribe them. We also see a population that comes in with only mental health disorders. So these are not serious psychiatric disorders that would warrant another higher level of care, as you discussed, but more of a safe place for them to address. Maybe they're not medication compliant, and we're able to get them back on board with the medications they use in order to help them with that. So I wanted to mention that's another part of the treatment we do. As we are a licensed psychiatric hospital, we're able to do that. Is there, just when somebody's nearing the middle or to the end of their stay on the unit, which could be anywhere from, I understand, well, I do know, but 3 to 10 days, it's a very short term. It's not a long-term program. Our residential programs are 30, 60 plus days. Outpatient can be, 6 months of treatment or longer. We also do what's called recovery support services, which is even services while they're in treatment that continue through all their program, even when they're finished with our continuum of care that we provide. But if somebody is going to their withdrawals and they're having a real difficult time, can you give us a little bit more about how we assist them during those rough patches of time? I know that I've seen them. Patients are coming up to our staff and having some difficult physical times, and they're just not in a place. And I know our team gets together, kind of huddles with the patient, with our nursing and psych team and counselors. But can you talk a little bit more about that so we're able to ease their process, I guess is what I'm talking about.
Sure. The medications that we might use with withdrawal, depending on the symptoms, can often be used for the psychiatric patient too, because they're not just unique just to drug withdrawal or alcohol withdrawal. The things that we use for nausea, the things that we use for headaches, the things that we use for body aches, these can also be used on the psychiatric patient, of course. The important thing I think to remember is that these patients are here for help. So many times they come in and they don't know what to expect. And as they go through the day, where they have a little bit of structure, where we're asking them to get up in the morning, to go to breakfast, to come to get their medications. We don't take the medications to them. They go and get their medications.
That's a good point.
When they are sleeping, we wake them up to go to groups. When it's lunchtime, we wake them up. And we have other activities for them where we have an activity counselor that comes and shares opportunities to relax and socialize, as well as times when they can go to what we call our canteen. They can go and get snacks and things like that. But as you had mentioned, a lot of them are coming in, they have a psychiatric or a psychological issue or drug and alcohol issue, and they're very uncomfortable there, not only physically, but psychiatrically or psychologically. This is a new environment for them. They're scared. They're around other people that are also struggling in the same way. And maybe they're used to being around people who are using drugs or using alcohol, or somebody who has gotten used to their behaviors with their psychological and psychiatric issues. But here we're trying to address those, and they become anxious and scared. And as a team, we try to address that. We do assessments for this. We encourage them to come and talk to the team. When we feel like something is escalating for them, like they come sometimes to nursing and say, I feel really, really sick. I don't know what's wrong. I feel like I have to get out of here maybe. What we'll do is we'll turn our attention to them, and we will call our postdocs, our psychiatrists, our psychologists, our counselors. We have social workers also on the team that are really good at coming in and talking the patients. What I want to, when I say is talk the patients down, so to speak, provide support and counseling and guidance, walk them through their process, walk them through their feelings. We also have medication to assist with this. If they become so full of anxiety, that we will give them something to help them through those rough patches. Our care is, like you mentioned earlier, 24/7 in the detox unit. There is always staff there. And I have been there both day and night. And there will always be a few people who are newer to the program who are up all night pacing the hallways. And what I've noticed is that the staff is very attentive to these patients. They sit them down, they talk to them, they ask them what can be helped. Sometimes these patients are in the shower multiple times. Sometimes they go outside and maybe they have a cigarette, which, we don't encourage, but we don't try to work with that too strongly when they're trying to go through other issues that may come a little bit later. But we do very much support them as they go through those very difficult psychiatric or psychological moments. We're there for them.
Thank you for that. You had mentioned earlier about groups, and I wanted to just talk a little bit more about that, because we're not a program where we just have patients come in and medicate them and they sit until they're complete. We may capture this patient. This might be the only time we see them. They may not go to a residential or an outpatient program. So we want to be able to give them all the tools. So in our program, if they're able, the first day we know might be a little bit difficult going through the first phases of withdrawal or their mental health. But we have groups throughout the day. We do a morning community group where we talk about the rules and the program schedule for today. The counselors and the nurses facilitate that. The nurses run medication groups to explain what different medications are in a generic setting, not pointing out to what medications our patients are on, but on these types of medications, this is what you might feel. We also do stress management classes and relax classes as well with our postdocs. We also have specific groups that deal with mental health and substance use. One of the biggest groups we have is relapse prevention, because we know that there might be urges to use while they're going through treatment. We've both seen that a lot, and we don't want our patients to leave prematurely. We want to be able to hold them till they get fully medicated and treated. Some people do leave prematurely, so we hold groups about that. What's going on with you today? How are you feeling? How can we avoid that type of stuff? We also do 12-step panels where we have people come and talk about, the 12-step program, and we do multiple, I can't even think off the top of my head, but there's downtime, there's quiet time, there's meals, and but throughout the day there are activities as you mentioned, with our activities coordinator and our recreation person that helps with that. So it's important that our patients get what they can get, because if they're only with us for 3 or 7 days, we want to, again, provide them with the most appropriate information and tools they have. And I know if you can talk a little bit about how you educate your nurses educate the patients on their medications upon discharge, that might be helpful information too.
Well, one of the things that my nurses try to do with patients is to review the medications that they're going to be leaving on. So sometimes our patients will come in and perhaps they have a seizure disorder, or perhaps they are on blood pressure medicine, or maybe even cardiac medicine. And when they leave, they're going to still be on those medications because these are prescribed by their own providers or even by our providers, but it's a medical issue. And it's not directly related to withdrawing from drugs or alcohol or their psychiatric concerns. And so with those medications, our nurses will make sure that the patients understand what they're on, how to take it, and why they're taking it. And then, of course, there are the medications that maybe they're being introduced to help them with their anxiety and their depression. Or, as we had mentioned, the Vivitrol afterwards, or the methadone that they might take after they leave. And our nurses also educate them about how to use those medications, why they're on those medications, and the signs and symptoms of problems that they might potentially see with those medications. Another very, very important medication that I want to mention here is something called naloxone. I want to mention naloxone because naloxone is a rescue drug. It is often called Narcan, and we do have some other brands as well. Example, Cloxato. Naloxone is a drug that can be given to reverse the effects of an opioid overdose. Fentanyl, as we mentioned in a previous segment, is an opioid, and patients can be taking this medication and not even know that they're taking it. So we educate our patients, and all of our patients have the opportunity to take naloxone with them. We educate them about how to use it and how they should react if a patient is starting to show the symptoms of a possible overdose, and how easy it is to give the medication and help them get over that. It comes in a spray, it goes right up the nose, you help them, and naloxone has been known, and I've seen it myself personally, actually bring a person out of an opioid overdose. And so we do provide that medication, we do provide that education, we provide them with all the education, we give them paperwork about their medications, and any questions that they have, we're there for them for that as well.
I think it's thank you. I think it's also important to know that if we're treating somebody simply for alcohol, we also educate them, because they might know somebody or have a need out in the community to have knowledge of Narcan and how to use it, because many alcoholics will come in and say, I don't need that, I'm not an opiate user. It's not about being an opiate user. It's a tool that helps save lives.
Absolutely.
And if we can educate everybody that comes through our doors that we treat to save lives out in the streets, then anybody can have it and anybody can take it. And I know we're a very strong component in that harm reduction type of helping those people that are on the street that some of them may not even get into treatment. We hope that we're able to do the best that we can with the need that is out there. Mm-hmm. So.
It's really important, I think, that the people that are watching this understand that, once again, Tarzana is not there to judge. Tarzana is not there to make a person feel uncomfortable or bad about the situation that they're in at that moment. We're there to help them. Many times when we have a patient who might be suspectful of possibly being an opioid overdose, they might express fear and anxiety of going to the hospital for emergency care, or even receiving the Narcan. They don't want it. It's important for people to understand that what we're there to do is to help them in whatever capacity that we can, including the risk of an opioid overdose. And so we don't judge. I love the fact that Tarzana is a very diverse and very accepting of all people within our walls, within our doors. It doesn't matter whether they, like I mentioned earlier in a previous segment, it doesn't matter whether they come from the streets or they're very wealthy, whether they identify as male or female or maybe non-binary. It doesn't matter to Tarzana. It doesn't matter whether they're rich or poor or young or old, healthy or having some problems. If Tarzana can help you, we want to help you. And that's the most important thing that I'd like to stress. You know, sometimes Tarzana is successful, and I love that when we are, but as I had mentioned in a previous segment, every once in a while, that person isn't ready. And when they're not ready, it's okay. Again, we're not going to judge them. We want them to come back when they are, whether it's psychiatric, psychological, whether it's drugs and alcohol or drugs or alcohol. When they're ready, Tarzana's there for them.
Yes, that I completely agree with that. That is a very good way to summarize the integrated care that we do for anybody and anyone. Tarzana is known has a relationship with the community that we will not turn people away. We will treat people that come in, and unfortunately we treated people that come in multiple times, and we've seen those people succeed as well too throughout their periods of recovery. So we are getting close to the end of our show here, and I just wanted to thank Dr. Olivarez for your time. It was a very excellent conversation. I always do appreciate talking with you, even in this environment and or in our offices or on the unit. But I just want to thank you very much, and I hope that the audience out there found this beneficial and helpful. And if there's anything that you need, please contact us. I'm sure the information is out there. And thank you very much. Appreciate it.
Finding Hope, The Road to Recovery. Brought to you by Tarzana Treatment Centers. You can visit our website at www.tarzanatc.org or call 1-800-996-1051.